the results of the FLASH 800 study that includes the full 800 cohort that was enrolled in the US. There's 200 more patients to be enrolled in Europe. It's a single arm, multi-center prospective registry. It enrolls all the patients that the local PERT team decided to recommend an intervention in the form of mechanical thrombectomy with a FlowTriever device. So it's not all the PE patients, it's just the PE patients that were treated with the FlowTriever device that, of course, met the inclusion criteria, which were fairly limited. And the design was to evaluate the safety primarily and the effectiveness of the FlowTriever system in the treatment of PE in an all-comer, all-inclusive patient population through 6 months. So the primary endpoint was the composite MAE, device-related mortality within 48 hours, major bleeding within 48 hours, an intraprocedural device or procedure-related AE. So we're talking about, did this device cause any harm, either in terms of cardiac damage, pulmonary damage, or to the patient as a whole. 800 patients enrolled from December of 18 to December of 2021, so relatively quick enrollment. We have the acute data for most of the patients. We have 6 months data for a large number of the patients. At the time of this analysis, a number of the patients were still in follow-up at 6 months. This essentially makes FLASH the largest prospective interventional study in PE, and there's a lot of sub-analysis that we'll see coming out of this. These are the baseline characteristics. I think this mimics our clinical practice in that we do not do this procedure in low-risk patients. We do not do this procedure even in low intermediate risk patients. The vast majority of the patients were in the intermediate high-risk PE. There's a fair proportion of high-risk PE patients here, so massive PE, about 7% of the patients. And this number probably would have been even higher if it wasn't for the competing FLAME registry in some of the centers. These patients have high PESI scores. The vast majority have positive biomarkers, large clot burden, concomitant DVT, which is often a forgotten risk factor for decompensation in PE. A fair number of these patients had significant pulmonary hypertension at baseline on presentation, more than 70 millimeters of mercury in 12.7% of the patients. And very important, 32% of the patients had lytic contraindication. So even if you think about a lytic first approach, that leaves you with 30% of patients where that wouldn't be feasible. Safety and mortality. Primary composite endpoint occurred in 1.8% of the patients, very low. Majority of these events were bleeding events. Majority of the bleeding events were defined as major because the hemoglobin drop was more than 5 grams. None of these events occurred since we introduced the FlowSaver. So a lot of that was due to the procedural blood loss. 3 intraprocedural adverse events, 2 clinical deterioration, 1 cardiac injury. This cardiac injury was a tricuspid valve injury that's not clear if it was related to the device as it was detected months following the intervention. Very important, no intraprocedural deaths, no cases of pulmonary injury with this device. All-cause mortality very low at 48 hours, only 2 patients. At the 30-day visit, similarly low at 0.8%. And at 6 months was 5%. So again, remember, there's a lot of patients with cancers here. There's a lot of patients with other comorbidities. So it's not surprising that, you still see mortality at 6 months. It made total sense for us to measure the hemodynamics in these patients when you take them for a procedure. I mean, it's a simple thing. It's essentially part of the procedure. You want to lead with a swung balloon tip catheter. And all you have to do is get a PA pressure and a PA sat. And that will tell you what's going on with this patient in a very sort of quick way. So the important thing is the FlowTriever mechanical thrombectomy leads to significant and immediate hemodynamic improvement post-procedure. So the mean PA pressure drops by 7.6 millimeters of mercury. This is mean PA pressure, not systolic PA pressure. Cardiac index improves at the same time in patients with depressed cardiac indices at baseline. And that combined leads to a decrease in the total pulmonary vascular resistance, which is essentially the ratio of these 2 parameters. And that's an important aspect because, you can drop a PA pressure if you take, 2 units of blood out of somebody, but that would also lead to a depression of cardiac index. So that we don't see this here. We see the numbers going in opposite direction, which is what you would expect. You want to see the RV doing better and at the same time, the PA pressure dropping. This was paralleled by a decrease in the heart rate. So the heart rate remains probably the most important surface clinical predictor of deterioration in patients with PE. I know Vic Tapson it talks about this a lot. The mean heart rate pre-procedure was 100 beats per minute. So again, fairly sick patients. It dropped immediately post-procedure to 89.5, so a significant drop, continues to improve at 48 hours. This was paralleled by an improvement in respiratory status with a decreased need for oxygen at 48 hours, to the point where 71% of the patients did not need any oxygen whatsoever. And 87% of the patients had an improvement in their oxygen requirement. The FLASH registry did not mandate echocardiographic follow-up initially. In the later stages of the registry, we tried to encourage site and create conditions to follow up the patients with echocardiograms to see the long-term impact. So that's why these numbers at the bottom here are not the same as the total numbers of patients enrolled. Nevertheless, in patients who had echocardiographic assessment at 48 hours and follow-up, significant decrease in RV to LV ratio. And this is the first time I'm talking about the RV to LV ratio, simply because it's something that has been used as a marker of RV dysfunction. We have much clearer and more direct measurement of RV function, which I just presented. This was paralleled by a decrease in RV systolic pressure at 48 hours, which continued to improve at follow-up. Similarly, RV function continued to improve to the point where at follow-up, the vast majority of the patients have normal RV or only mildly depressed RV function. And the important thing here is that a lot of these patients had echocardiograms because of, standard of care, but also because potentially they weren't doing that well, or they had large PEs. So it's biased towards looking worse, if anything. It's impressive to see these numbers looking as good as they do. The longer term data and the readmission rate. Readmission rate was very low at 6.2%. Most of this was unrelated to the PE treatment. Again, speaking to the comorbidities these patients have. And the long-term sequelae at 6 months, CTEPH was 1.2% and CTED was 2%. Now, there is a question in the data entry whether the patients have CTEPH or CTED. However, the adjudication of this is not independent. So this is just site dependent. We actually looked at some of these patients, and at least half of the CTEPH patients, if not more, already have fairly high PA pressures at the original event. So it's not incidence, it's prevalence more than not necessarily related to the index event. So where does this sit in comparison to what's out there? So again, obviously there is different studies, different selection criteria. But the important thing is, not having a randomized control data in this registry using the state-of-the-art technology in thrombectomy. Are we trending in the right direction or not, right? And obviously we are. If you're looking at the mortality data, so just hard endpoints, mortality relative to what's published in the PERT database, 5,000 patients, 10.2% mortality versus 0.8% mortality. Again, not apples to, this is not, it's apples to oranges to a certain degree, but it's important to see that this numbers trend in the right direction. Same thing from this large meta-analysis recently published looking at CDT versus anticoagulation, where the mortality, in fact, in the control arm was similar to the PERT database numbers. 30-day readmission, again, this is a yes or no type of thing. There's not much play here. It's very high, 24.4%. Again, this is from the PERT database versus 6%. So numbers look encouraging. Looks like we're going in the right direction. The FLASH 800 data has been published simultaneously in neurointervention. This was a gargantuan effort, as they told us they want to publish these results just a few weeks before the actual presentation. So the paper writing took a lot of effort from everybody. And I'm happy I had the chance to lead this effort, but this wouldn't have been possible without the co-investigators that are listed here. And most importantly, with the team from Inari that supported the science behind this. This is a little add-on, and this is kind of interesting. More recent data. This was not part of the original presentation. But it makes you wonder, is there something about this technology, or are all these devices the same? There's a lot of newcomers in the field of thrombectomy for PE. A lot of companies are repurposing thrombectomy devices that are started somewhere else, either in the stroke space or in the peripheral space, and go into the PE space. The most advanced of which is the Penumbra system that has a fairly wide base, use base currently. And if you're looking at, this is from an insurance database, looking at cases, PE cases where these devices were used. If you're looking at mortality, it's striking that the mortality with the FlowTriever is lower than the mortality with Indigo. Now, of course, these are not the same patients. But I think that what's even more interesting is the same-day lytic use, and this has less to do with the patient population. But this is a crude indicator of if you want procedural failure or insufficient procedural success, which is markedly different between the FlowTriever device and the Penumbra device. So very, very intriguing data. Of course, this needs to be validated and looked into in a more sort of prospective fashion. But again, as I was saying about the mortality number and the readmission numbers, the numbers look very promising. And why is this? So if you're looking at, this is a graph actually from Penumbra. So there, this is a device that's connected to a pump. The current device is 12 French. The original device was 8 French. And if you're looking at the top bar here, this is the suction that this device applies to the tip of the catheter continuously, right? And the argument here is that this suction is continuous as opposed to a syringe, or as opposed to the current inari syringe where the pressure drop is very quick. But does this really matter, right? I mean, a continuous suction on a catheter that's not engaged to clot will just result in tremendous blood loss, essentially. So what really matters is this part here, is the initial clot engagement force. This is where you make contact with the clot. That's the first, when the catheter is very close to the clot, you create this suction and immediately contact the clot. And if you're looking at this part, the difference in pressure is not that high, right? It's only 2 millimeters of mercury difference between the inari system and a syringe, basically, a 60 cc syringe. But what's impressive is the force. So if you do this, a little bit of physics calculation, and the clot engagement force is pressure by the surface, and a 24 French catheter has a much larger surface area than even a 12 French catheter, you see that the clot engagement force is about 3 to 4 times higher. So essentially, think about the weight you can pull with this catheter, with a smaller catheter versus a larger catheter. And I think the best example of that is what happens when you do a clot in transit case, where you have the catheter. This is an ICE-guided procedure that we did a few months ago. You see this clot popping back and forth with the tricuspid valve. And this is the inari catheter that's not essentially engaging the clot, sits in the vicinity of the clot, but because of this rapid and abrupt suction effect, you can engage the clot very quickly and take it out.